You can start.
So, good afternoon, all our participants. Today is a milestone in the history of ICOG. FOGSI ICOG, under the leadership of President FOGSI, Dr. Smita Tendulwarkar, and Chairperson Dr. Parag Biniwala, is starting a program of teaching learning methods by the name of Odyssey of Teachers. It is a program for teachers, by the teachers, and of the teachers. And it is important to run with the time, run with the pace of the time, and understand what are the changes are being done in the medical education system. Medical education is evolving significantly over the years to meet the needs of the learners in today's ever-changing healthcare environment. The activities also need to evolve and become more skill-based, providing hands-on training, experience to students in real clinical settings. So now the focus is more on the student-centered, outcome-based teaching that actively engage students in learning process rather than traditional teacher-centered didactic teaching lectures. So these changes has come with the approval and insistence of National Medical Commission. So NMC has really taken this task, and they are widely spreading this new method of teaching learning. So this Odyssey of Teacher is series of pan-India online learning method. This is an endeavor by our chairperson, Dr. Parag Biniwale, to sensitize and train the faculty of all medical college, DNB centers, or all centers where teaching learning is being practiced, to impart medical training to all the postgraduate all over India with this newer interactive style of teaching and learning methods. So what we are going to do, we are having series of modules covering various teaching methods, and these modules will empower not only the teacher, but the postgraduate students as well in becoming better lifelong learners. So each module will be discussed each day and demonstrated by a group of eminent teachers from all over the country by including various clinical scenarios. So today, we are planning to have module 1, which will focus on small group discussion method of teaching. So let's embark on this journey of discovering and refining the art of teaching and learning. And I have with me my coordinator, Dr. Vidya Thobi and Dr. Vandana Agarwal, and our FOGSI ICOG chairperson, Dr. Parag Biniwala. So I request Dr. Parag Biniwala to welcome all our participants and address us.
Thank you, Dr. Ashok. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to be addressing all of you today on the first episode of Odyssey of Teachers. It was almost more than 8 months ago when Dr. Ashok came with an idea that there are so many changes that are taking place as far as teaching methodology is concerned, and NMC has introduced new norms which may not be known to medical colleges, especially in the remote places of the country. There are so many senior teachers who are actually involved in this. I jumped at the idea and thought that we should get into something like this through ICOG and try and reach out to more and more teachers who are giving so much knowledge to the undergraduate and postgraduate teachers. So after a lot of brainstorming, we have finally come up with the program, and we intend to do it we are trying to do it every month. And I must appreciate the efforts put in by the coordinators, Dr. Ashok Kumar, Dr. Sheila Mane, Dr. Vidya Thobi, and of course, our young dynamic Dr. Vandana Agarwal, who's the new in charge in this program. My best wishes for the program, Dr. Ashok and the entire team, and I welcome all the professors who have given time to ICOG for conducting this activity. So today is the first episode, and I sincerely hope that it reaches out to a lot more people and is useful activity of ICOG. In fact, last week when I was addressing some of the professors in the Haryana at Mulana, they were really excited that such an activity is thought of by the ICOG. So, best wishes to all of us because we want this activity to continue and to be useful to all the professors who are not yet well versed with the newer teaching methodologies. Thank you very much. Over to you, Ashok.
So thank you, Dr. Parag, for your thoughts about this program and about the teaching learning methods. And I will just emphasize again that it is indeed a pleasure to be a part of this program. And yes, under your leadership, ICOG has again shown its ability to face the challenges and try to introduce new things for the benefit of the academics in India. With these words, now I would like to express my sincere thanks, and I will welcome all our teachers today who are there with us in the program. We have Dr. Niharika Dhiman, Dr. Vaishali Kode Nayak, Dr. Lata from JIPME, Dr. Kavita Singh, Dr. Madhav Prasad, Professor Vinita Singh, Professor Kavita Bhatti, and Professor Tamkin Khan. Along with, we have so many other faculties and junior consultant who have taken part in each activities, and they will be demonstrating all these methods of teaching learning of small group discussion. Like today we are going to have, there's so many methods, but we are going to demonstrate fishbowl method, jigsaw method, controlled discussion method, and think, pair, share method. So these we are trying to understand how small group discussion can be done and what are the benefits and how or what are the pitfalls of each method. So each session is devoted on these lines, and I hope with your suggestions, inputs, and feedback, we will be improving each program day by day and try to incorporate your suggestions or advices, whatever is good for the development of these programs for the benefit of teachers. So with these words now, I invite my friend, Dr. Vidya Thobi, to say a few words and continue the proceedings.
Ashok, before you call Vidya, let's have the inauguration prayer followed
Yes.
by Dr. Sunita's message, and then we
Yes.
start the program.
Yes, sir.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मा मृतं गमय ॐ शान्ति शान्ति शान्ति.
Vandana, we can play Dr. Sunita's video, which was recorded.
Yes, ma'am. Yes, sir. Gauri, if you could please play the video.
Yes, ma'am.
Hi, this is Dr. Sunita Tandilwadkar, President FOGSI 2025. First of all, I welcome you for this wonderful program. It's beautifully crafted, designed by ICOG chairperson Dr. Parag Biniwale with his team, Dr. Ashok Kumar, Dr. Vidya Thobi, and also our chairperson-elect, Dr. Sheila Mane. This is indeed an hour of a need. There is so much of an advancement in every field of OBGYN. May it be endoscopy, infertility, reproductive medicine, may it be fetal medicine. And it's very difficult for the teachers, especially to get the leave from their medical colleges and keep on attending and increasing their knowledge in the subject. By attending this program from ICOG, it will be wonderful for them to know what are the advancement they are happening, and then they can percolate this information to their student. Basically, this will evolve the students from all the side. I may not tell the name of the college which I visited last week, but one of the student got up when I had an interactive session. She said, "Ma'am, our teachers are not aware these advances in infertility or obstetrics even, and probably that is because the government colleges may not be so well equipped, and the teachers may be excellent, but the availability of this information may not be there. So this program which ICOG 2025 is coming out is absolutely applaudable. And I congratulate all, and I wish each and every teacher to come forward and, if possible, get their students also in this program. So you save your time in passing on the same information to the students. Also, the advantage will be we will be having the vision for the student, whether they are interested more deeper into obstetrics, urogynecology, infertility, endoscopy, oncology, fetal medicine. OBGYN has become now super specialty in every aspect. They can start thinking where they should see, what they should see. And then after they finish the post-graduation, they can just develop themselves into the particular branch. When the teachers are having the knowledge about these advancements in the particular field, automatically the department will be uplifted. Thank you so much for your patience. Thank you.
Thank you, Madam Dr. Sunita Tandulwarkar, President FOGSI, for enlightening words and giving us few advices and showing the direction how to go about. So with these words, Dr. Parag, with your permission, we can continue with the program now.
Dr. Suvarna is here, so let's
Right.
ask her to address us because today is
Dr.
the first
Swarna
program. Thank you so
Kadilkar is
much.
the Secretary General of FOGSI, and she has always cooperated with us for all our endeavors. So, Madam, please, the stage is yours. Please unmute. Madam, please unmute.
Yeah. I hope I'm audible now.
Yes,
Yes,
Suvarna.
yes.
Yeah, I'm not going to talk for long. I think audience is very, very eager to know this absolutely innovative teaching program, Odyssey of Teachers. I have really known Dr. Ashok Kumar, Dr. Vidya Thobi, and Dr. Vandana Agarwal, who have been so, I can say they are into teaching, medical teaching for several years. So, and along with Dr. Parag Beniwale, Dr. Sunita Tandulwadkar, Swati, Sheila Mane, and Dr. Sarita Bhalera, the whole team has really made a fantastic program for the audience and students and teachers. That I like the first tagline which you have written in the brochure. Students don't need a perfect teacher, they need a happy teacher who is going to make them excited to come to school and grow a love for learning. This is Professor Richard Feynman, and this is how apt for this program or these programs like this. I congratulate each and every one. I hope you all have a fantastic learning experience. And I was just speaking to Dr. Vidya just before this. And as she said, the small group discussions and various different types of teaching programs have become now mandatory at the NMC level. So I hope that these type of programs are conducted more often and they are of help to most of the teachers, students, and mentors. So, wishing you all the best, Dr. Parag, Dr. Sarita, Dr. Ashok Kumar, and Dr. Vidya and Dr. Vandana. Wishing you all the best. You have a great speakers lined up who are going to talk on various aspects of online learning methods. So, I wish you all the best. Thank you.
Thank you.
Thank you, madam. So now we start with Dr. Vidya Thobi. Please take over and continue the proceedings.
Thank you. Thank you very much, Dr. Ashok Kumar, that he has included us as a coordinator, and it is a privilege for us. Thank you, Dr. Parag Biniwale and Dr. Sarita Balerao, and my co-coordinator, Dr. Vandana Agarwal. It is indeed a pleasure to start this program right away. Today's module, as Dr. Ashok Kumar has told, is about small group discussion, method of teaching, and we are embarking the journey of discovering and refining the art of teaching and learning. Now we all know that NMC says that it is always student-centered and not the teachers. So there are various methods to how to make the students more engaged and our teaching more interesting. So every year content becomes less and less important and its availability becomes increasingly ubiquitous. When human beings have tools to learn, they have got many tools, teaching learning methods. So anything of their own, they start learning. There is YouTube, there Google, SlideShare, and they learn a lot. And what is correct, what is not, the teacher is always there. But facts are very important. Knowledge is very precious, and you can't understand the present unless you understand the past. So there are various positive and negative aspects also we are going to discuss today. And definitely we will start with today's first session. So can I share my screen back end?
Yes, ma'am.
Vandana?
Yes, ma'am.
Dr. Neelam she's a little unwell. So I'll be doing her presentation right away here. So just give me some time here. No, this is not the presentation, right? Dr. Vandana,
Yes, ma'am.
till then you just introduce what Dr. Neelam Roy wants to say about, and you introduce her so that I will share her screen. Yeah.
All right, ma'am.
Yeah.
So Dr. Needham Roy, madam, is the Director Professor and Head Community Medicine at ABVIMS and Dr. Ram Manohar Lohia Hospital, New Delhi. Unfortunately, she was unable to join us because of health concerns. So Professor Vidya Thobi, madam, has very gracefully accepted a last-minute call to present on her behalf. Neelam Roy, madam, is the Associate Dean of PG exam. She is the Coordinator of Medical Education Unit, Treasurer of Indian Public Health Association Delhi chapter, Executive Member of Indian Association of Preventive and Social Medicine, member of various expert committees, and has numerous publications under her name.
Thank you. So I'll be doing her presentation right now. Not getting the...
Backend team, could you please open up Dr. Neelam
Open up,
Roy's
yeah.
PPT? Or
Yes,
I'll
ma'am.
open it and share it.
You can share it, no problem.
Gauri, are you able to open it? Dr. Neelam Roy,
Yes,
ma'am.
ma'am. Yes, ma'am.
Yeah, please share it.
So this is regarding small group teaching methods, and there are many methods which we are going to discuss. Vandana, please share yourself. Yeah. So in this, there is this is a base, that is introduction, advantage and disadvantages of small group teaching learning, methods of small group teaching and learning. Next slide, please. Yeah. So what is a small group really? No one right size for a small group. The size of small group can vary greatly in medical education. 5 to 8 learners are optimal, but it may extend up to 20. If there are 250 students, you can divide them into a smaller group. So minimum is 5 to 8, maximum is 20. What is a characteristic of small group teaching? One is there should be active participation, purposeful activity, and always in a small group, you always know that it is a face-to-face contact. These are the various advantages of HD. As I speak, please change the slide. So advantages of small group discussion: democratic way of discussion, there is a problem solving, how you present, so your presentation skills improve, communication skills improve. Then there is a interpersonal dynamics, interdependence, common goal, division of labor, teamwork, sense of responsibility, celebrate the differences also, and acceptance of the differences in opinion. So these qualities also get developed. Participants who may need more assistance can be identified and help may be provided. So in 20 group, some might be having very good communication and some might be very good presenter also. So they can exchange these ideas. So small group has got these advantages. So I very well know that this presentation might be boring for others who have joined, but definitely stay back here, because after this presentation, we are going to demonstrate how we are means imbibing these qualities and how we are demonstrating amongst the students. Now, these are the disadvantages of small group discussion groups. One is time consuming process requiring skilled moderator and facilitator. Sometimes we lose sight of slow learning, objective discussion may get off the track. Pre-rider effect, not every student in the group contributes equally. Social loafing, when a person exerts less efforts to achieve a goal when working in a group than working alone. And there is a student's diversity. Some participants talk too much and some may just passive listener. This always happens. And there are logistic difficulties. So these are the disadvantages of um, small group discussion. So again, in this, manage the learning, manage the activities, and manage the group. These are the three key roles of the facilitator who is managing this small group. The main procedural steps are: small group discussion mainly contributes to circulate the information on pre-decided topics. So topic is decided beforehand only, and it generates in-depth discussion. The important steps are introduction of the topic with the objective, then directing this topic to the discussion by the group leader, and then we summarize the discussion at the end. So this is the procedure. So small group discussion, one is you can have a didactic interaction between the facilitator and individual learner, or there is a multiple active interaction between the facilitator and individual learners and their peers. So this is what happens. Cognitive knowledge domain. Now, what is this? Then there are this cognitive knowledge domain one has to create. One is put into information together in a newer way. Then comes evaluate. Justify the stand or decision. Then you have to analyze. Break the concept into parts and then understand how each part is related. Then whatever knowledge is there, you have to apply this knowledge. Use this knowledge in new ways. Then comprehend and understand. Explain the ideas and the concept. And then you have to remember. You have to recall the facts and what are the basic concepts. So these are the cognitive and knowledge domain. So what is the foundation? Foundation for small group discussion, when there is always active learning, deep learning, and experimental learning. So these are the three foundations. Now today we are going to have fishbowl discussion on how it goes, control discussion, then there is simple jigsaw. And these are all we are discussing today, all these four, and think, pair, share. So these are the four techniques of small group discussion we are going to learn. Now today, the first session will be on fishbowl method. Students are seated in two concentric circles. 4 or 5 chairs are arranged in the inner circle. Remaining chairs are arranged in the outer circle. The moderator introduces the topic. Then those in the inner circle actively discusses the topic. Outer circle observes them and takes the notes. And afterwards, the roles are reversed, allowing all students to participate actively. It encourages the active listening and thoughtful participation. This is the fishbowl method. The types of fishbowl is again closed fishbowl and open fishbowl. This is a closed, this picture on the right side, you can see the closed fishbowl. The initial participants speak for some time, and when time runs out, they leave the fishbowl and the new group from the audience enters the fishbowl. This continues until many audience members have spent some time in the fishbowl. Once the final group has concluded, the moderator closes the fishbowl and summarizes the discussion. In open fishbowl, any member of the audience can at any time occupy the empty chair and join the fishbowl. When this happens, an existing member of the fishbowl must voluntarily leave the fishbowl and free a chair. So the discussion continues with the participants frequently entering and leaving the fishbowl. Now, what is a jigsaw technique? This is the second part we are again today discussing. Means we are demonstrating that technique and we are giving the topic and the technique is discussed. So here what happens is it makes the students dependent on each other to succeed. It breaks the assignments into pieces that group assembles to complete. The success of jigsaw method in the classroom relies how the space is organized and the dynamics is within it. Creating an inclusive environment where the sharing and whatever learning they are doing from one another feels very, very natural and it is imperative. The steps, again, we are discussing there later, so I'll not skip this. We will be discussing when we are discussing a proper jigsaw method. So there are expert groups, then there are exchange, then there is a conclusion. And we assess all the students on various subtopics. This is very interesting. The third one is a control discussion. Here, the teacher comes in. So it has emerged as a transformative approach that promotes active participation, critical thinking, and collaborative thinking. By prioritizing dialogue over monologue, the educators can create dynamic classroom that prepares the students for complexities of the modern world. The direction of discussion strictly is controlled by teacher. That is the advantage. Now here again it is split into first is discussion, give the topic selection, then prepare the question that you have to set the ground rules first. Then initiate the discussion and then facilitate the dialogue. Then you have to summarize and reflect and some productive and impactful discussion comes out. So this is how the control discussion takes place and there the teacher is the main moderator there. Now think, pair, share. The think, pair, share is structured around 3 core stages. One is think. First is think. The student is given the question or prompt a brief period to think about their response individually. This stage promotes the independent reflection and allows the student to formulate their thoughts without pressure. Then you have to pair. Then the students are pair up with the partner to discuss their thoughts and ideas. And this collaborative phase enables them to articulate their thinking, consider alternative perspective, and refine their understanding through dialogue. Third one is share. Finally, pairs, they share their insight with larger group or class. This stage broadens the discussion, allowing for a variety of viewpoints and ideas to be presented and examined. So this is how the think, pair, share looks like. In round one, the students think or write about the discussion question. Now, 1, 2, 3, 4 are the group. Then we pair 1 and 2, 3 and 4, and 3 they share with they exchange and share with each other. So this is how it happens. There are other small group discussion techniques also. Next slide. So here what happens is there are lectures, there are panel discussion, group discussion, there are seminars, symposium, brainstorming, buzz group, and workshop. So these are the various techniques and methods which are used in group situation, bring about the group act. There is free group discussion. Student themselves, they control the topic and discussion, and teacher is just observer. Now what I told is, now it is all student is a focus. So self-directed learning, what we call it as. So there it has come out, and here the students are the main people who are learners. Now they are learners only, but they have got their thought processes. Now what about the brainstorming? There is an intensive discussion, spontaneous ideas, and solution to a problem. They generate new ideas and they improve the creative thinking. There are buzz groups also. 2 to 6 members, they discuss an issue for a brief period within a lecture or a group discussion. It is an active learning process and it breaks the monotony of a long lecture. If you give 30 minutes lecture, the brain has got capacity for only first 20 minutes. Later on, it has got a fatigue or there is a distraction. Here what happens is 6 members are discussing and it is a active learning process. So it always breaks the monotony. T group, that is therapeutic group technique, discussion on their relationship and problems in the human relation. So this is another discussion point. Syndicate, class is divided into groups. They work on one or interrelated problem. Joint report at the end of for the appraisal of whole class. Mind mapping, a graphical way. There is a graphical way to arrange a topic into piece of paper. It is an interactive method where the creativity is increased and students focus more on the topic. In conclusion, this is the last slide, next slide. Wherever you are an experienced teacher or new to this approach, the techniques and strategic method here provide a roadmap for enhancing our teaching skills. Let us endeavor to grow and evolve as a skillful teachers and facilitators, and watch out our students to transform into active and thoughtful and lifelong learners. So we all are, even though we are teachers, we are lifelong learners, I must say. The future of education lies not in delivering knowledge, but in co-creating it through a meaningful conversation. So with this brief introduction, I must say that we will start with our first session. And I'm very thankful that all the great teachers here have joined with their students. I see our speakers, all speakers have joined. I'm very thankful to ICOG for giving me opportunity. And let us start, Dr. Vandana, with our first session. I can see Dr. Niharika here.
Yes,
And
ma'am.
she is, she is with her students. Dr. Sheila Mani, if she has joined, I wanted to take few comments from her also. But
Yes,
if
ma'am.
she
Madam is here.
joins late, if she joins late later.
I am here, Vidya.
Acha, acha. Okay, Dr. Sheila, I was told that you were in emergency. I want your comments also. And after one session also, you can give comments. She
Yeah,
is a very
I
great
think
teacher, Dr. Sheila Mane. She is a chairperson elect of our ICOG. We need not, everybody knows her. So I want her
yeah,
comments. Yeah, Sheila.
yeah, thank you. I think now everybody has expressed their views, and I really congratulate Dr. Parag, Dr. Ashok, and Dr. Vidya for taking this initiative. And as you have nicely explained and narrated now about all the methods of teaching, what we are going to discuss today, and I really think it is very important that this type of teaching will not be monotonous, and students' active participation will play a very big role. So I won't take much time now. I congratulate everyone. And as well, I would like to welcome all the teachers today who are actively participating, and Dr. Vandana for taking initiative with this with Dr. Ashok. And I think it's a really innovative thing which ICOG has started. And congratulations to all of us in fact, that the college has to do all these things, and we have started this. So best
Yeah.
of luck. And
Thank you.
yeah.
Yeah.
Thank you.
I want Sheila to tell her DNB students also to participate. I think she has shared the
I
link
have
to
already
Yeah,
shared. Yeah,
yeah,
I
yeah.
just
So
once
you
again I
have
tell.
yeah. Thank you very much. Thank you.
And the teachers
Thank
from
you.
all over
Thank-
I have shared. Yeah.
Yeah. Yes. So let us start with our first session number 1, that is fish bowl method.
Yes, ma'am.
Can I have the introduction of the first speaker? These are the experts, Dr. Niharika Dhiman. She is a professor in the Department of Obstetrics and Gynecology, Maulana Azad Medical College, New Delhi. She has got many associations like our Indian College of Obstetrics and Gynecology, National Board of Medical Science, and so many associations like NARCHI, AOGD, and FOGSI as well. And she has got awards, international award in education and research, and many, National Association of Reproductive and Child Health, and she has won the prize also. She has contributed a lot in campus and various project investigator as well. And she is a great teacher. I have observed her personally at Delhi also. She has got a field of interest like gynae, oncology, and critical care. So Dr. Niharika and our other experts and other expert on this is Dr. Vaishali Korde Naik. She is professor and head of Maimer Medical College, Pune, and she's a great close friend of mine. Consultant Critical Care Obstetric Ruby Hall Clinic, Pune, also Executive Vice President, Pune OBGYN Society, Fellow Maternal and Fetal Medicine at Singapore, Associate Editor of Journal of Obstetrics and Gynecological Practice. I must say that Pune OBGYN Society is the first society, they have their own journal. And international examiner for Royal College of Surgeons, London, and she has got recipient of many awards. So welcome Dr. Vaishali also for this session as expert. And we are going to demonstrate with Professor demonstrate. These are the demonstrator for this session. Professor Kamna Datta, Dr. Neha Mishra, Dr. Shilpa Tholia, Dr. Vandana Agarwal, Dr. Rimchim Raina, Dr. Mamta K. Meena, Dr. Madhulika Kotwal, Dr. Palvi Sharma, Dr. Preeti Yadav, Dr. Samiksha Kharbanda, Dr. Manisha Chandel, Dr. Pranjali Yadav, Dr. Ritu Yadav, and Dr. Ritika. I welcome all enthusiastic students over here who are going to participate on this first method, that is fishbowl method. I welcome Dr. Lata from Pondicherry. I just saw her. So welcome Dr. Lata as well. Okay, yes.
Thank you, madam. Niharika, ma'am, over to you.
Yeah, yes. So Vandana, you can share Dr. Niharika's presentation. She is going to explain. I think in short, I have explained about the fishbowl method. I think you can just make it short and start with our video presentation.
Yes, ma'am. Niharika, ma'am, would you like to present it, or shall we tell the backend people?
Okay, I'll share my screen.
Better.
Yeah.
And all your students have joined, I think. No?
Yes, ma'am.
Yes.
So the
okay.
students from Maulana Azad and ABVMS and Dr. RML Hospital, ma'am.
Can you see my slides?
Yes, we can, ma'am.
Are they moving?
Yes.
Yeah. So very good afternoon, everybody. And I'm very delighted and privileged to be a part of this new initiative which ICOG has taken. I would like to congratulate each and everyone who have actually made it possible. And thank you, Vidya ma'am, for the kind words and introduction. So as ma'am has already covered what is fishbowl method, I would just like to highlight the important points that you need to consider while conducting a fishbowl method. Yeah. So fishbowl method is one of is it? Yeah. So fishbowl method is one of the methods of taking a small group discussion, which I assume everybody of us is doing as per the NMC new curriculum. So initially, what we need to know is what are the steps of doing a fishbowl method. So the first step is to select a topic with multiple perspectives. That means multiple perspective here means topics which are, difficult to take in seminars, lectures, or, which have a difficult understanding per se by the students, or where you require in-depth knowledge of that particular topic, or topics which are debatable, or there are dilemmas in terms of their diagnosis or management. And particularly one must not choose topics which have some emotional component attached to it, such as, counseling or taking consents. For this, you might prefer a role play rather than a fishbowl method. So step 2 is setting up of the seating. As ma'am has already said, you need ample amount of space. You need to arrange chairs as per the number of students you have in the small group, where you need to arrange the chairs in a round circle, which forms the inner circle, and chairs arranged around it, which forms the outer circle. In case you have many participants, as we know the undergraduate batch is almost equal to 250 students, and these small groups might, go up to 30 or 40 students. So what you can do is you can increase the number of layers of the outer circle, and the outermost, it is preferred that the outermost circle, in the outermost circle, the students can stand, so that there is face-to-face interaction, and they can actually see and kind of note down what the discussion is going into in the inner circle. So that's important. Yeah, next is preparation time for student. As already emphasized, ample time has to be given to the students when they are preparing for a fishbowl method. What we particularly do is when we release the curriculum for the small group discussion, the topics are already given to the student, and we give them at least a week to prepare for the group. And a week before, what we do is we kind of allocate or divide them into the inner and outer circle, and ask them to choose their participants, and ask them to allocate roles of each participant. We also tell them the goals, what are required from that discussion. So this has to be done before the actual discussion happens. Other is establishing discussion norms and rules. This is important in terms of which type of fishbowl you are preferring. Either it is a closed or a open fishbowl method, which I'll be discussing later. But important thing is you should always tell the students how much time you are giving to them for the discussion. That is important. Another part is that debriefing after the inner discussion is over. Debriefing should be done, where what we need to do is the SLOs, or the learning objectives, which have already been highlighted by the facilitators, are discussed by the outer circle, and also the group dynamics in terms of how the participation went as per the student involvement is also discussed, and a conclusion or summary is also given. So we already know the role of facilitator, that we already know. So basically you as a teacher act as a facilitator here and kind of direct the discussion that is going on. It should not go haywire. So that has to be taken care by the facilitator. Now the inner circle, the participants of the inner circle, basically they are asked to choose a leader. And the role of the leader is to, kind of allocate or subdivide the topic amongst the inner circle participants. There's a scribe. Scribe basically notes down all the discussion points and keeps a check whether, the goals have been met or have not been met. So the scribe can also prompt in between that this topic particularly was supposed to be discussed, but has not been kind of discussed in the discussion. And a very important role of the timekeeper. As we all know, these small group discussions tend to consume a lot of time. So the timekeeper basically keeps a note of the time and prompts in between in case they overshoot the time limit. Yeah. And they actively, the inner circle participants actively discusses the topic amongst each other. So an in-depth discussion is done. For the outer circle, basically the outer circles are observers. But apart from observing, what we do is we give them a particular format to all the participants of the outer circle, where they need to note down, while the inner circle is discussing, they need to note down the group dynamics, the content of the discussion, and jot down few key points from the discussion. And why this is important, because as we know that these days undergrads and postgrads have to maintain a logbook. So what they can do is these notes can thereafter be attached in the logbook, or can be written as reflection, or made into an e-portfolio, which will further help in the formative assessment. So already discussed, there are two types of fish bowls, closed fish bowl and open fish bowl. Whenever you start attempting, or whenever you start to do a small group discussion by a fish bowl, it is preferred you can do a closed fish bowl first, because it's easier to kind of regulate the group and the discussion goes in that direction. After you are well versed with the closed fish bowl method, you can move on to the open fish bowl method, where the interaction happens between the inner and the outer circle. So I think this has already been discussed. Just important point regarding closed fish bowl is that the discussion happens only between the inner circle participants. The outer circle participants are listening and taking down notes. And once the discussion of the inner circle finishes, there is a role reversal. And in the end, either the leader of the inner circle or the facilitator is going to summarize the key points. Open fishbowl method, if you plan to do discussion by open fishbowl method, it can be done by various methods. One is switch method or tap method. The other is empty chair method, where in one of the method, what happens is the outer circle participant feels that there's some point that he or she wants to add. So she just goes and taps onto one of the participants sitting in the inner circle and asks her to asks her to kind of so that the change of role happens, and the inner circle participant goes on to the outer circle. Whereas in an empty chair, what happens is one participant from the outer circle occupies that chair, and the another volunteer from the inner circle goes and sits in the outer chair. So it is kind of interaction. There is an interaction, limited interaction, I would say, between the inner and the outer circle. So what are the advantages and disadvantages? As for the advantages, it helps in open communication, maintains transparency. There is ideation and creativity. There is equal participation to a much degree. And the discussion is quite engaging and inclusive. And it facilitates differentiated learning. So various different topics, which might be difficult to learn, so that it helps in kind of facilitating the differentiated learning. It promotes deeper understanding of topics which are actually difficult to comprehend, and generates new ideas and solutions. As for the disadvantages, these disadvantages can actually be controlled by the facilitator. They can kind of minimize the amount of the disadvantages by actually kind of regulating the group dynamics. So the disadvantages are there can be observer disengagement, potential of interruptions, awkwardness of some participants, and may not be suitable for certain topics, as I said, and it can be time consuming. So these disadvantages can be taken care of. Yeah, so to end, I would like to say this is one of the quotes by a renowned American educator, that medical education is not just a program for building knowledge and skills in its recipients, it is also an experience which creates attitude and expectations. Thank you. And now we'll be playing the demonstration of fishbowl method. And here we have chosen a topic, the placenta accreta spectrum and blood products. So, and I'll be the facilitator for this fishbowl method, and we'll be basically demonstrating the closed fishbowl method. Yeah. So over to you, Vandana.
Backend team, please play the video. Gauri.
Yes, ma'am.
So very good afternoon to all. So we have gathered here to do the fishbowl method of small group discussion, and today we'll be doing the closed fishbowl method of discussion. And as you already know, you have been allotted a topic 1 week back, which is the placenta accreta spectrum and blood transfusion and blood products. So today basically we have chosen 5 participants as participants of the inner circle, and we have our participants which will form the outer circle. So this batch is divided into two groups. So basically the role of outer circle I would like to emphasize first. Outer circle will be, observers to this discussion, and you have been given a format. In this paper you will note down the inner discussion which is going on, and basically you will note down the group dynamics, the content of discussion, and you will also write down some of the key messages. Okay, that has to be done. The inner circle will be involved in a didactic discussion on placenta accreta spectrum. The goals for discussion of this topic for the inner circle is you need to discuss the latest definition, the high risk factors, how will you diagnose the case of placenta accreta spectrum, and what are the various management protocols that have to be followed. So we begin the discussion. First I would like to ask the duration for your discussion is 15 minutes. Please go by the time so that we can carry on the discussion by the outer circle also. So I would now like to ask the inner circle to please choose a leader, a scribe, and a timekeeper. So you've decided?
Yes, so we have decided as the inner circle, me, Dr. Kamna Datta shall be the leader of the group. Dr. Neha Mishra will be doing the role of scribe, and Dr. Shilpa Tolia will be keeping a check on the time. Okay. And we shall be going through the definition, risk factors, etiology, diagnosis and management of placenta accreta spectrum. And to begin with, placenta accreta spectrum is defined as abnormal adherence of placenta either in focally or completely. It is basically abnormal trophoblastic invasion, begins with that. So when there is abnormal adherence of placenta, it can occur in three forms, like placenta accreta when the adherence is abnormal, placenta increta when the invasion of myometrium is also present, and placenta percreta when the invasion crosses the serosa. Because the adherence is abnormal, there is risk of torrential hemorrhage during separation of the placenta, and thus it becomes a very important factor while prevention of maternal morbidity as well as mortality. Anticipating the pathology, adequate precautions in terms of blood transfusion, ICU, multiple disciplines, and proper patient consent and information are key roles for management of this disease. So, Dr. Vandana, will you like to tell us the risk factors for occurrence of placenta accreta spectrum?
Yes. So the most common risk factor associated with placenta accreta spectrum is history of previous cesarean sections. As the number of previous cesareans increase, the incidence of developing placenta accreta spectrum increases.
Any other risk factors?
Yes, there are other additional risk factors also, like advanced maternal age, multiparity, history of any uterine surgery. It could be a myomectomy, a curettage, or if the woman has had Asherman syndrome.
So out of all these, which is the most significant risk factor?
So the most significant risk factor is history of placenta previa.
Dr. Vandana, we are short of time, so please keep this in brief.
Okay. So it is said that placenta accreta spectrum occurs in 3% of women who have placenta previa without any history of previous cesarean. And if she has previous cesarean along with placenta previa, the incidence of placenta accreta spectrum exponentially increases. If you talk of numbers, it is 3, 11, 41, 60 and 67% for the first, second, third, fourth, fifth and more cesareans respectively.
So it is very obvious that the risk of placenta accreta increases exponentially as the number of placenta previous cesareans increase. Dr. Neha, what is the etiology for this?
So my basic etiology is defect in endomyometrial interface, which leads to excessive trophoblastic invasion, impaired decidual function and abnormal vascularization.
Okay, so these factors, wherever this happens, so that can lead to placenta accreta in the future pregnancies. So, and Dr. Vandana, can you just, for the knowledge of the outer circle, can you tell us just the most common, risk factor which is actually associated with accreta spectrum?
So it has been seen that previous cesarean along with placenta previa.
Okay.
That is which leads to the maximum risk of having placenta accreta spectrum.
So remember, previous section with placenta previa, you will go with the mindset of morbidly adherent. Yeah.
Now it's such a deadly problem. How do you diagnose it?
Ma'am, based on clinical assessment and image modalities, we can predict placenta accreta spectrum. Ultrasound is a primary tool for diagnosis of placenta accreta spectrum. Feature suggestive of loss of retroplacental clear zone, placental bulge, placental lacuna.
So just a minute, please, Mamta. So is there's a cross conversation going on? Any point you want to highlight, or Dr. Mamta?
Ma'am, me
something?
and Shilpa were just discussing that could Dr. Mamta elaborate on the role of color Doppler and power Doppler in diagnosing placenta accreta spectrum disorders?
So, Dr. Mamta, you told us about ultrasound. So, basically asking, is there any role of power wave Doppler also?
Yes, ma'am. Color Doppler is another indicator of diagnosis of placenta accreta spectrum, which is suggestive of increased prevalent blood flow to the area. But MRI used as a complementary tool when the placenta is posterior, and ultrasound finding is inclusive. But confirmed diagnosis be made on by histopathological report.
Okay, so good. So that means you mean to say if you want to order one investigation, it should be ultrasound with power wave Doppler?
Yes, ma'am.
Okay, and in case it is inconclusive, then we go in for a MRI.
Yes,
Yeah.
ma'am.
Thank you.
Okay, now once you have diagnosed, a diagnosed case of placenta accreta spectrum comes to you in labor, how do you manage this patient?
Mainstay of the management is the surgical management. Basically, after delivering the baby by a classical cesarean section, we should proceed for the cesarean hysterectomy. But when there is a densely adhered bladder or intense vascular involvement, then we can go by posterior retrograde hysterectomy also. And we should approach by the multidisciplinary, our approach should be multidisciplinary approach. And we should activate the massive blood transfusion protocol also along with the surgery.
So very important, massive blood transfusion protocol should be activated, multiple disciplines should be involved. Is there any other method of managing?
Yes, ma'am. There are certain patients where we can go for conservative management. Like a first subset patient is like one young woman who desire to preserve fertility and have focal accreta, where we can do conservative surgeries and preserve the fertility. Another subset of patients where disease is so extensive that we want to do delayed hysterectomy. There, where our goal is to save the blood loss and injury to the vital organs. There are also conservative management could be tried.
So which patients will you choose for surgical management in terms of cesarean hysterectomy?
As I said, the cesarean hysterectomy is the mainstay of the treatment, gold standard treatment, because it's a one-step procedure, and placenta accreta is a life-threatening situation, and there is a higher risk of hemorrhage. So we should, mainstay of the treatment is the cesarean hysterectomy, but only in few cases we can go for conservative management. Although we will face the major problem is the fertility loss is the major concern when we are doing cesarean hysterectomy. And there is a risk of organ injury like bladder and bowel injury when there is an extensive involvement of these organs like in cases of placenta percreta.
So Dr. Neha, conservative approach looks very good. Are there any disadvantages associated with this?
Yes, ma'am, there are certain disadvantages like secondary hemorrhage, sepsis. Patient can go into septic shock, and ultimately it could lead to multi-organ dysfunction also if not diagnosed in time. But yes, considering the median blood loss of 3.5 liters in placenta percreta cases and the incidence of bladder injury, we can opt for conservative management. But yes, case selection should be done intelligently.
Okay, so
Yeah,
I think
Dr. Neha and Dr. Shilpa has covered both the debatable topics of management. So I think the take-home message should be that surgical management is the gold standard. However, very few patients can also be chosen for conservative managements. So I think Dr. Kamna, your group has
yes, I think we
covered it well.
finished for the time being. And
yeah, so now the inner circle has completed their discussion. I hope the outer circle has jotted down all the points in terms of group dynamics, content and key messages. Okay, now we are going to ask few questions from the outer circle. And you know these papers, that format we have given to you, these all you can go back and put it in your logbooks as reflections, or prepare them as reflections, or you can even kind of put it them as e-portfolio for your formative assessment. Okay, so don't lose these papers. Okay, so if I ask you, Dr. Ritu, did you feel that the group dynamics went well?
Yes, the group dynamics were very well followed. The discussion done by inner circle was very focused in depth and concise and with time kept in check.
Okay, thank you, Dr. Ritu. Dr. Pallavi, what are your views on group dynamics?
Every member of the inner circle played nicely and almost equally. I have also plotted a organogram.
Okay.
Dr. Kamna participated 4 times, Dr. Shilpa participated thrice, Dr. Neha participated thrice, Dr. Vanna participated twice, and Dr. Mamta also participated twice.
Yeah.
So
So that means they were equally active and
participated.
participated well. Okay. Thank you, Dr. Palvi. So, Dr. Madhulika, did you note were there any cross conversations in the inner circle?
Yes, ma'am, there were cross conversations, but the flow was maintained.
Flow was maintained.
ma'am.
Okay, so yes, good. Thank you, thank you. So I would like to ask, what are the key points, Dr. Preeti? Any key points, take-home messages you would like to tell us?
From what I could infer, the most common risk factor for placenta creta spectrum is history of previous cesarean, but the most significant is placenta previa. And power wave Doppler is the mainstay of diagnosing placenta creta, but in cases where the placenta is posterior and the report is inconclusive, we can go for MRI.
Yes, very good, very rightly said. Dr. Manisha, any key points you want to add?
I could very well understand the management. It can be further divided into conservative, but the gold standard being surgical, classical cesarean with total hysterectomy.
Yes.
Multidisciplinary action should be taken, as well as massive blood transfusion protocol should be activated.
Yeah. So I would like to ask you that Samiksha, how do you feel being a part of the outer circle? Did you feel left out at any point of time?
No, ma'am. It was a very nice experience. In total, I jotted down all the important points that added to my academic knowledge, and I feel that it is a very nice technique for topics which have such diagnostic dilemma.
Okay, so you think we should carry this method for other
Yes, ma'am. It is
topics
a very
also?
nice teaching method.
Okay, thank you. So, Dr. Rimjim, did you feel that in-depth discussion was done, or you think some topics were left uncovered?
I think pretty much all the topics were covered very clearly, but what I feel was missing out was post-operative management and follow-up in case a patient is being conservatively and not surgically managed.
Okay, so I would like to ask anybody from the inner group could answer to that query which was left uncovered.
Yeah, very rightly pointed out. We probably missed this. So post-operative care becomes very important, especially for women who are managed with conservative surgical methods, because these are the women who are at a higher risk of sepsis and hemorrhage. So we generally call them weekly for the initial months, so as to assess the patient at every visit. And for patients who have undergone cesarean hysterectomy, they are relatively better off in the sense but they are at a risk of transfusion reactions which can come at a later date. So they also need to be followed up for the complications which can occur in these patients. So generally weekly for a month, and then monthly for 6 months, and thereon it's fine.
Yeah, so here we end the discussion by the inner circle. So at the closure, I would like to ask Dr. Kamna to please summarize, give us few key points for the discussion.
Yeah, so I would like to take inputs from the timekeeper, Dr. Shilpa. What was the total time?
We took 12 minutes total. In total, we are very much in time.
Okay, so 12 minutes was our time, and Dr. Neha has jotted down important points during the discussion of the inner circle, and I would like to summarize all the points by looking at the points taken by our scribe. The placenta accreta is abnormal adherence of placenta. It can occur in 3 forms: placenta accreta, where there is abnormal adherence, placenta increta, where there is invasion of myometrium, placenta percreta, where there is invasion till the serosa. Most common risk factor is previous cesarean section, though the most significant risk factor is placenta previa, but there are other risk factors like advanced maternal age, previous uterine surgery, so they have to be kept in mind. And coming to the etiology, it's abnormal trophoblastic invasion. We diagnose this generally by ultrasound with power Doppler, only in cases where the placenta is posterior, or in cases where the ultrasound is inconclusive, we can go ahead with an MRI to diagnose placenta accreta spectrum. It is very important for us to diagnose it antenatally for a good management of this patient. While managing, a massive transfusion protocol is activated. The blood bank, ICU, anesthetist, neonatologist, and other disciplines like urology and all should be taken into consideration. It is a multidisciplinary approach many times. Classical cesarean section followed by cesarean hysterectomy is the gold standard of treatment, but there are conservative surgical methods available for women who have focal placenta accreta or those where the invasion is so high that the risk of intraoperative bleeding and adjacent organ damage is very high.
So you do a
And
delayed hysterectomy.
we
in
can
those.
have a interval hysterectomy in them. And post-operative care is important, especially for women who have had conservative surgical management.
So thank you, Dr. Kamna. I think they have very well summarized the topic also. So now you all are clear about the first topic, or the first part of the small group discussion, so placenta creta spectrum. Now the second part of the discussion is the blood transfusion and blood transfusion products, for which we are going to change the roles. As outer group has already prepared the topic on blood transfusion, they will become the inner circle now, and the inner circles will observe the discussion of the outer circle by noting down the points. So thank you. We now complete our small group discussion.
I heartily congratulate the whole team, Dr. Niharika and all Dr. Kamana and all the team members. They presented the whole fishbowl method so excellently that we can incorporate this type of small group discussion in our whatever teaching we are doing in our medical colleges or wherever you are doing. So we have our expert, Dr. Vaishali Kordenayak, who is a professor, head of the department, Myanmar Medical College, Pune. I have already introduced her in the start of our this session. I welcome her again, and please comment on pros, cons, in which topics we can incorporate, in which topic we cannot take up this fishbowl method. So please comment on these aspects. Over to Dr. Vaishali.
Yes. Very good afternoon, madam. Am I audible?
Yes, yes, very much audible. Yes.
Can I have my presentation, please?
Okay.
I
You
would
can share your presentation if you
Yes,
have sent in.
Yes. I would initially like to congratulate ICOG for selecting this, because this was very much restricted to medical colleges and NMC and our MEU cell, and we have been taught about this. But being a real Indian college, ICOG under the great leadership of Dr. Parag Biniwale has taken this, and I really would like to congratulate Dr. Parag Biniwale sir, Dr. Ashok Kumar sir, Vidya madam for selecting this, and this would be beneficial for everyone, for the teachers, for students, everyone to understand it. Dr. Vandana, she is really coordinating it so very well. And now the video which we have set, basically this whole idea of explaining it and then showing a video which represents how exactly this system or this method works is excellent. It gives a very good clarity to the subject, and it helps us to understand how exactly we can implement it in our day-to-day teaching. So I would again like to congratulate Dr. Niharika and the MAMC team for a very elaborate video which was having a good representation of this method. Now coming to the feedback. As fishbowl technique is a small group teaching, and we all medical colleges are having batches from 150 to 250 students each, it really becomes sometimes difficult to implement. But if we select good topic, distribute the time, we can definitely use this small group teaching methods and apply it for our large groups. So the pros of this method, we have this develops a good listening skills, especially in the outer circle. It initiates critical thinking in both the circles, and the inner circle students especially get a good enhanced communication skills, so they know what are the important points and those points to be highlighted. It actively engages all of them, the speakers as well as listeners. So as we have seen in the video, both the groups were very actively engaged in the whole topic. I would just say that if we select a topic which has multiple aspects, like in this case, if we keep it like surgical management versus conservative management, then the students can come up with diverse perspectives of the various managements and then give their advantages and disadvantages, which actually brings the utility of such kind of methods more distinctly. It definitely fosters the teamwork and make us all work together for the better understanding. The cons, next slide please. The cons of this method, as we see, there can be some students with little attention deficit. There can be some students who are having good speaking skills, or they can have a dominance over this. And the balance we need to maintain. Sometimes fishbowl technique or fishbowl method turns into debates rather than a deliberation, which we have to take control of. And in some students who are little anxious about they have stage fear, then there it becomes a anxiety provoking in some of them, and time management really becomes crucial. Now coming to this video, next slide please. They have very nicely demonstrated. The very important thing was this was very pre-planned and the students were given enough time to prepare. There were clear instructions that what the inner circle and outer circle students were to do. Inner circle maintained a very good group dynamic. They had distributed themselves as leader, scribe, and timekeeper. The outer circle were also given the task, the content. They were to jot down the group dynamics and also take home messages, because sometimes it so happened that with the content and the group dynamics, we don't want them to miss the topic, because that is the main core that they need to understand. So by asking them about the take home messages, it becomes very clear that they are in the discussion and they have received the important messages. So that was very well followed here. And I also liked one point which Dr. Niharika said, that we can encourage our students to have these papers attached in their portfolios, and that can help them in their formative assessments, which is again a NMC requirement. So that was a very good suggestion here. The cross conversation between students was well controlled and avoided. I still want to be on the same slide, please. The time was very well managed, and the reflections from the outer circle, they helped the group to again achieve whatever was the small lacunae were there. And the most important part of this method is the debriefing and the summary, because the main points, the take home crisp messages, we have to ask them, get them back, and again, maybe the facilitator or the leader of the group can give the summary again, so as to have a good impact on the students, that what is important and what is the crux of the subject. Next slide, please. Now, this method which was used here was a closed fishbowl method. And if you can see that in open fishbowl, there is always an empty chair kept. So usually I like to do open kind of fishbowl. In this, the outer circle, any member from outer circle who wants to add a point or contradict a point can always raise a hand. Once the person inside inner circle stops speaking, then that person can come and sit on this empty chair, and then we allow that person to have their point of views. So it sometimes help engage the outer circle people more or involve them more with the core subject. And this kind of open fishbowl method is also one method where we can have different perspectives about the same topic. Next slide, please. So this is how it is, the moderator here and the empty chair, and anytime this person can come back, sit here, or any one of them can leave and keep one other chair open. So usually when there are debates or certain issues, ethical dilemmas, or certain issues where there are different perspectives are needed, we can also use this. But yes, time management becomes crucial. So this is one method which can create interest in this. So these were the points from my side, and definitely this initiative is very well appreciated by all the teachers. We just saw Vidya Madam's message that we have to mail. We will definitely mail, and we are telling on upfront that these are the topics which we should be we should be continuously discussing and enhancing our knowledge. So congratulations ICOG and MAMC. Thank you.
Thank you.
Thank you, Dr. Vaishali.
Yeah, thank you, Dr. Vaishali, for the in-depth feedback, I would say. And I would also like to thank RML team, which was with us in the participation also, and all the contributors. So RML and MAMC, getting them at one place at one time, that to two tertiary centers, is another difficult group dynamics to be maintained. So I thank my contributors. Yeah.
We understand and we appreciate. Great efforts.
If any questions are there, please put in the chat box. We would love to answer them. I think we will move to the second session, Dr. Vandana.
Yes, madam.
Yeah. So let us move to the second session. Yeah. So in the session 2, we are going to demonstrate jigsaw method. Next slide, please. And here we have two experts, Dr. Lata Chaturvedula. She is a professor of obstetrics and gynecology, JIPMER, Pondicherry, and my dear friend. Faculty of Medical Education, JIPMER, President, OBGYN Society, Pondicherry, Executive MBA, and FICOG. Have two ICMR funded project, COVID in pregnancy, and she has got areas of interest like high risk pregnancy, high risk obstetrics, preventive oncology and infertility, passion for normal deliveries, guide for past 24 years. She has to her credit many publications and some chapters in books. She's a great organizer also. I had a witness to attend two conferences in Pondicherry under her able guidance. So thank you very much, Dr. Lata and her team. Next slide, please. And the next expert is Dr. Professor Kavita Singh, President, All Madhya Pradesh OBGYN Society 24 to 26, Professor Dean GMC Bhopal, ex-professor and head of the department NSCB MCH Jabalpur, Governing Council member ICOG 24-25, President Madhya Pradesh GOI 23 to 25. So she has got many credits to her awards and credits, and she had got many publications as well. Welcome, Professor Kavita, and there are many demonstrators here, Dr. Purva, Dr. Aishwarya, Dr. Abhinaya, Dr. Gopika, Dr. Indranil, Dr. Jyotika, Dr. Kirtana, Dr. Prashant, Dr. Sakshi, and Dr. Tanya. So there are many demonstrators here. So over to Dr. Lata for her second session on jigsaw. Yes.
Yeah, thank you, Dr. Vidya, and for this introduction. And I should thank Dr. Ashok and Dr. Vandana for giving us this opportunity. I hope we do a appreciable job. I'll just share my.
Please, at the back front, many people are entering. Please admit them.
Yeah. So I bring you greetings from. Should I start?
Yes, madam.
Yeah. I bring you greetings from Pondicherry. So this is the jigsaw method of learning which we are supposed to do. So to introduce, actually Dr. Vidya has already given the introduction, but I'll just start off. Jigsaw is an interactive method of small group learning. We nowadays don't talk it as teaching, we talk more in terms of learning. It has been used since 1970s and it is learning through peers, moderated by a single faculty member, and it helps in problem solving and critical thinking which can be fostered. It is not usually feasible among individual learners. This is only for group learning. So how do we go about it? Usually we give a topic a day or two prior, or even whatever number of days, 3 to 4 days earlier for the learners. And the batch of students are divided into expert groups. You can have groups of 4 to 6. And in each group you can have 4 to 6 members, and maximum number of groups of 10. Depends on whom we are administrating adopting this kind of method of teaching, whether it is for undergraduates or postgraduates. Because we have 250 undergraduate students, obviously we need to have maximum number, but today we'll be concentrating on postgraduates. So each group, the size and number of group depends on the number of subtopics. Suppose you have 4 subtopics, then you have 4 groups with 4 members each. If there are 5 subtopics, there will be 5 groups and 5 experts in each group. And all the subtopics are discussed in the expert group first. So first topic will be given with subtopics. The whole subtopic will be discussed in the expert group. I'll show you how it is done. After the discussion in the expert group, each member of the group, main group, is assigned one subtopic, and each participant will gather points by initially, before they go to other groups, they'll individually think on what all they have learned in their group about the subtopic. After this, all those who have chosen the same subtopics get together and discuss in the subgroups. I will show you how it happens. Whatever new points discussed in the subgroups are gathered by the individual members, and then they go back to the parent groups. Again, rediscussion is done in the parent group. And after this, one expert from each group will discuss in the plenary to bring out all the points. Okay, so what happens is, towards the end of it, feedback is taken from all the participants. Both the feedback is all about merits and demerits and limitations of this method. Then the points are debriefed by the moderator. And one thing is, this topic sometimes it's not possible to discuss entirely the topic in one particular session. So this topic can be even discussed in 2 to 3 sessions. So I'll just tell you what is. So we have chosen right now for this demonstration 3 groups. So you'll have group A, will be labeled as A1, A2 and A3. Group B, you have B1, B2, B3. Group C, C1, C2, C3. I will tell you why they are labeled like this. So once the main topic is given, they discuss the subtopics in the group. So A1, A2, A3 will discuss, likewise B1, B2, B3 and C1, C2, C3. Then what happens is, we have the subgroups. In the subgroup, what happens? All the ones from each team will come together. A1, B1, C1, likewise A2, B2, C2, and in team 3, A3, B3, C3. So each team will discuss the first topic will be discussed by team 1, the second topic will be discussed by team 2, and the third topic will be discussed by team 3. So they gather whatever new points which they have not got from their expert team. After this, they'll again go back to their expert groups. Like this, again they'll rediscuss the points which have been discussed in the subgroups. Okay, this is how it is done. And for this task today, we have discussed the main topic which I've given them is RH negative pregnancy. And the subtopics are the pathophysiology, management, and prevention. So I'll just share the video. Just a minute. Sorry.
Is the audio available for all, or am I not able to listen?
Not able to hear?
I am not able to hear.
No audio, Lata.
1 second.
Our backend team can play it, ma'am, if
I
there's
think
an issue. Gauri, if you could please play it. Yes.
Is it turned now? Yeah.
Yes, ma'am.
This jigsaw method, we will have 3
subgroups for this particular activity. Each group
Little louder. Little louder.
so we have 3 groups here. The topic which I am assigning to you today is RS pregnancy, right? So among that the subgroup will be pathophysiology, management and prevention. So first you will discuss among the groups, among all these subtopics. I will give you 10 minutes to discuss about this. After the discussion is over, at the end of 10 minutes, we will stop. Okay, now shall we have the 3 members introducing themselves? Team A, please.
I am Tanya Sana. I am Jyotika. I am Aishwarya.
Is it not audible?
It's audible,
Yeah,
ma'am.
Dr. Lata,
All
you
good.
better you speak along with the video. So that would be better.
Group discussion?
It's okay. I mean, I can hear it, ma'am. Maybe
So
the network
basically
issue.
here we had started the discussion. So the discussion is happening among the 3 groups. Obviously, we cannot concentrate much on each group because it will take time. So we just showed how the groups will be sitting initially and how the discussion is happening here.
On the graphs, and that is how further management was employed based by dividing.
So they are discussing among the groups about each subtopics which I have given. That is the pathophysiology, the management and the prevention of RH immunization.
Zone 1 was we can again monitor.
Zone 3, if the baby is in zone 3, we will not terminate, we will see the gestational
We
age.
will see the gestational age.
Have a neutralizer. So it forms a rosette formation. If that is positive, then we proceed.
So simultaneously there are discussions going on in all the groups.
Fluorobensky test, or we can do by flow cytometric KB testing. KB testing is nothing but acid infusion technique. What is the main rationale behind that is fetal hemoglobin, that is HbF, will be more resistant to that of the acid. So if you HbF, so when you apply when you subject that to that test, what happens? All this HbF will all be maternal blood.
No, the thing will be audible in laptops. Most probably in the phones, it may not be very audible.
Yes, ma'am.
With the advent of immunoglobulin, if anti-D is given, anti-D1, then post-natal, then there is a reduction of the chance of isoimmunization reduces to about 2%. And with when we give it anti-D1, it can reduce it to 0.2%. Now, anti-D can be given at 28 weeks of gestation. This is told by ICOG.
So in each of the groups, we will be again having sub numbers. So if we have a group, we have 3 groups, right? Group A, Group B, Group C. So group A will have A1, A2 and A3. Group B will have B1, B2 and B3. Group C will have C1, C2 and C. Now what are we, why is this A1, A2, A3, B1, B2, B3, C1, C2, C3 is in the group? So A1, suppose A1 will talk about pathophysiology, all the ones, A1, B1 and C1 will talk about pathophysiology, A2, B2, C2 will talk about management, and A3, C3, B3 and C3 will talk about prevention. Then all the ones will come together, all the twos will come together, and all the threes will come together. That means A1, B1 and C1 will come together as team 1, A2, B2, C2 will come as team 2, and A3, B3, C3 will become team 3. Now again in this what you will do is the group team 1 will discuss about pathophysiology. Each of you will put in points and you gather all the information. Likewise in team 2 you will gather all the information about management. In team 3 you will gather all the information about prevention. And after, I'll give you 6 minutes for this for discussion. After that you will go back to your parent units. All the A's will be together, all the B's will be together, all the C's will be together. In this what you do is whatever new information you have got about what happened? Any problem?
Any problem, Gauri?
B1, B2, B3, C1, C2, C3. What you will do is, should I share my video again? Team
one will
Coming now, ma'am. Kind of.
Each of you will put in points and you gather all the information.
Maybe we can fast forward to some timestamp, ma'am.
You will
Yeah.
gather all the information about management. In TNG, you will gather
No,
all
ma'am,
the
it's not
information
possible to
about
fast
prevention.
forward.
And after, I'll give you 6 minutes for this for discussion. After that, you'll go back to your parents' units. All the A's will be together, all the B's will be together, all the
There's some problem, Amma.
information. Likewise, in team 2, you will gather all the information.
Is it getting stuck? Should I share?
Gather all the information about.
Gauri, is there some problem with the internet?
I'll give you
Should
6
I or Lata madam share?
After that, you'll go back to your parents' units. All the A's will be together. all
Ma'am,
the
you
B's
can
will-
share the video.
Ma'am, Lata ma'am,
But
would you
this-
like to share?
Yeah, I'll share, but you're saying there is some problem with the 1 second. Huh?
Let's try
1
it,
second.
ma'am. If not, then I'll do it.
Let me see. 1 second. I'll just try. Is it heard? Is the volume heard?
Not yet, ma'am.
No, we are not listening anything. Audio
Not
is
heard?
no, not heard.
Ma'am, listen, when you're sharing this,
Can you share it, ma?
Vandana, you try sharing your.
I'll try it, ma'am, once.
I don't know what is the problem, but
Are you able to listen?
no.
Yes, ma'am.
Yeah.
No, we are seeing, but did you put the volume on?
Yes, ma'am, I have.
Vandana, you need to go to the settings and share the audio through computer. Go to the settings of Zoom.
Okay.
All right.
Settings of this thing, huh?
I think setting of your computer.
Dr. Lata, can you hear me?
Yes, we can hear you, Dr. Ashok.
Dr.
Yeah.
Lata, please, you take over and continue with whatever you want to convey the message. Then we will have another next expert opinion. So because there is some problem with the video, so you try to see what all you want to convey in the video and then we go ahead.
So can you just show the video at least? Okay, I'll share the
Yeah.
video myself.
Yes.
1 second, I know what happened. 1 second. I'm so sorry for this. I don't know what has happened.
It doesn't matter. It happens sometime, but
doesn't matter.
please continue. We will not waste much time here. You please continue with.
Yes, sir. You are able to hear now?
Ma'am, we are able to hear you. You may speak on the topic and
Okay. Are you able to hear now? No.
No, we can see the video, ma'am. Maybe you can
Okay.
speak on it as we see the video.
Means the delegates have understood the method. Now
Yeah.
you
So
just
what we have
demonstrate,
done
yeah.
is, this is that groups where we are seeing group 1, 2, and 3, where they're doing the subgroup discussion.
Yes.
After this, they will come back to the parent groups and again they will discuss whatever they have learned. This is how we do it.
Yes.
So now they're giving the feedback. Feedback means what they have learned and they're presenting in the plenary. So here what they do is, from each group, one person chooses to talk. So that's how they've done. So they'll tell all about management, what they have learned. And so this they are talking about, the C group is talking about the prevention. So now they're giving the feedback. So what the feedback is, they said each one of them have discussed. So there's a lot of interaction between the students and they get a lot of knowledge. So they say group discussions usually are directed less, but here because of the subtopics, they're able to talk, they get a lot of information from everyone. So so says because the topic is given earlier, they've used multiple resources. So they're able to, bring in a lot of information from people. But however, there are certain negative feedbacks again, because so the limitations will be like it cannot be used by an individual. People, it will take a lot of time to organize. Again, they have to get together, especially for residents. They have to be together. So getting all the residents together is also it takes a lot of time.
Okay, madam. So can we have now Dr. Kavita madam to give your inputs, madam?
Expert opinion.
I'm so sorry for the video.
Yes, no problem, madam.
No problem.
Hello,
Whenever
good
it is
afternoon,
possible,
everyone.
yeah.
So Dr. Kavita madam is there?
Yeah.
Yes,
A
yes,
very good
madam.
afternoon.
Yes, madam.
Yeah. At the outset, I would like to thank Dr. Ashok Kumar, Vandana, and Dr. Parag, Dr. Vidya for remembering me for educational reason. So right now I am in a train traveling. So Dr. Purva is assistant professor in the Department of Obstetrics and Gynecology at Gandhi Medical College. So I would request Dr. Purva to quickly go through the presentation. Then I will share my experience as far as this method is concerned. Over to you, Dr. Purva. Purva is a wonderful. She is my ex-student. Now she is faculty in department. So over to you, Purva.
Thank you so much. Thank you for the opportunity, ma'am. At the outset, I would like to thank Ashok sir, Vandana ma'am, and Vidya ma'am for giving me the opportunity. As rightly demonstrated by Dr. Lata ma'am from Zipmer, jigsaw method is basically a a work which is requiring a lot of teamwork. So in ancient time, why there was need of this method, it is because the students come from various different backgrounds of different personalities and skill sets, so there was lot of difference between them. But when we move on to our traditional classroom approach, it is basically they behave more like a competitor, and individualistic mindset is different, and they behave like rivals, and they want to be first at whatever the thing may be. So the genuine learning point has been lost at that point of time. So in 1971, there was one social psychologist, Elliot Arison, who basically described this cooperative learning theory, and the jigsaw method was a was one amongst them. As we have already seen in the video demonstrated by Dr. Lata ma'am and her postgraduates, it is each student is behaving like an expert. So it basically fosters teamwork, active engagement, and mutual reliance. It boosts the motivation and is effective across the subjects. So we have seen that they were divided among the groups. Then they move on to a different home group, and then they come back and share their experiences and the knowledge amongst themselves in their parent group, and then they have done their feedbacks. So the steps of the jigsaw are very well demonstrated in the video, and there are various variations also of this jigsaw method, like reverse jigsaw. In this, the home groups present to the expert group. The home group which we have made will present to the expert group. Some uses online tools like digital collaborative tools for the presentation. That is the online jigsaw method. There is one jigsaw 2 method. In this, all read the same topic and then they specialize. So these are the variation among the jigsaw methods and the various adaptations which has been taken into consideration. So, as we have already seen the advantages, that it is a fantastic method of a group work or a teamwork with a positive solidarity. In this, individual is responsible for a specific subject. The heterogeneity is very much there. There is sustainability of the study. The students develop a leadership quality and a way to cooperate with each other, and equal opportunities for success. These are the basically the pros of the jigsaw method. As very well said by Dr. Lata ma'am, कि there are some challenges in this. That is, if this method is a little, it is little cumbersome in terms of time, and the teaching struggles are there in some cases. There is sometimes unequal participation by the participants. The planning and preparation and all are very much required. The time commitment, the time especially in the postgraduate students, it is very difficult to collect them in a group, because they have different working hours and different duties assigned to them. And also the in-depth knowledge is of a particular subsection is there, not of all the section. So these are the some of the challenges which we face in the jigsaw method. Otherwise, it is a very great method of a teamwork and a group work method. Thank you, ma'am. Over to you, Kavita ma'am, for the expert.
Yeah. So very nicely and very in a crisp way, you have emphasized the importance and limitations of jigsaw. As far as I hope I am audible.
Yes, ma'am.
Yes, ma'am, you
Yes,
are.
ma'am.
Yeah. So as far as my experience of jigsaw is concerned, particularly in the PG group, attempted in PG group, and in PG group, like when we go ahead with a team like Dr. Lata said, ABC, here we mix up with a peer learning. So we take one student from like PG first year, another one from second year, and another one from third. So how we can, make maximum advantage of this method is that whenever like if we start with the prevalence and etiopathogenesis or some start house officer, and if it is something to be explained in between clinical symptoms and presentation, we take PG second year, and when it comes to management, we take PG third year. So this is how, so whatever example, if it is a preterm labor, so all three aspects will be given to a little edge of seniority to that group of PGs, so that the topic is totally covered, and there is nothing like competition or someone sitting silent, because there will be an active participation when we involve all three students. As far as in UG classes is concerned, I have not attempted because of multiple reasons. So the very good method for PG and small group teaching. So this is all my input, and at this I can see Dr. Yogesh is also in the platform. So I want to thank you for all your educational material forwards whenever you give on the MAU group. So with this, thank you, Dr. Ashok. I am going for a JOX installation to Jabalpur. If you have some ICOG message as a state president, I can share.
No,
Because,
ma'am, thank you. Yeah. So thank you very much, Dr. Kavita, for your experience really matters, and whatever you have told us from your experience, it matters, and it gives us the understanding of the methods. So, Dr.
Yeah.
Vidya, please continue with the next
Yeah,
session.
yeah. Thank you,
Yeah.
Dr. Ashok. And we
Thank
are
you.
running
Thank you.
short of time.
Thank you
And
so much.
thank you, Dr. Kavita, in spite of you're in train, you have joined for your expert comments. I really appreciate
No,
that.
I just
so
take this
this is something
opportunity.
common amongst us is love
Yeah,
and
yeah.
interest in
Yes.
academics.
Thank you,
Yeah.
thank
Thank
you.
you. Thank you.
Can we
Dr. Vidya, I
go?
just want to thank all my residents for
Yes,
participating.
Dr. Lata. Yeah.
The studio of JIPMA. So sorry for the audio, and I again thank all of you for giving us this opportunity.
Thank you very much. Thank you. So let us move to the third session. Can I have the third session's
Dr. Madhava Prasad, CV.
Yeah. Dr. Madhav Prasad is busy in his UG exam. So he's an associate professor at St. John's Medical College. So he's busy. So on his behalf, Dr. Vishnu Priya has joined from his unit. I know Vishnu Priya is there in the audience. Please unmute her if she's there. Dr. Vishnu Priya, are you there? Vandana, please check if she's there in the audience. And
Yes,
the second, Dr. Vinita
we can start playing the video on
Yes,
controlled discussion
madam,
in
we
the meantime.
continue with the video. We will
Yeah,
have
we
the
will continue with the
input.
video.
Yeah.
And let Dr. Vinita Singh gives an expert comment. Vinita Singh, we all know she's a professor OBGYN at Patna. So she'll be speaking as an expert. So demonstrators are Dr. Vishnu Priya, Dr.
Yes,
Sri,
madam.
Dr. Shreya and Leena Shri, Dr. Ridhika, Dr. Pritika, Dr. Jabin, Dr. Helen, and Dr. Sylvia. So let us play the video.
Gauri, please play the video.
Yeah. We have already explained what is a method. Yeah.
Yes.
The risk factor also can be cocaine abuse for abruptio placenta. Cocaine abuse. Okay, cocaine abuse is a risk factor. Can we look at something more common? It includes hypertension, preeclampsia, or maybe trauma. Right. So hypertension and preeclampsia related entities are a lot more common entities in the day-to-day scenario that we see. While what you answered was, is well known, but it is not really common. Right. So moving on, what are the various types of abruptio placenta? It can be concealed and revealed. So if you confirm the abruptio placenta, if it's concealed, they won't be bleeding outside. But if it's revealed, you will see bleeding. Correct. So,
ಹೇಳ್ತೀರಾ
conditions
ಒಂದು
where
ಮ್ಯಾರೇಜ್ ಆನಿವರ್ಸರಿ ಟುಡೇ
how can you differentiate
43 years
in placenta previa, typically there is bright light vaginal bleeding and it is painless. But in abruptio placenta, there is painful bleeding. It's dark red in color and it's associated with uterine tenderness and contractions. And sometimes in abruptio placenta, they might not be bleeding at all. In which case, there is only abdominal pain, which is very severe. Correct. So, to summarize, so we have increased uterine tone, color of blood. These two things are going to help you to distinguish between abruptio placenta and the placenta previa. Moreover, we can go into a little more detail. There are the two types where there is abruptio revealed and there is abruption which is concealed. Any other distinguishing factors between the two?
In placenta previa, the uterus is relaxed, the wall is relaxed. But in abruption placenta, there is a very tense uterus. So this is a clinical feature.
So these are all abdominal findings. Can we look at some general physical findings?
In uterine fundal height corresponds to justice to age in placenta previa. Whereas in abruption placenta, the uterine size is slightly more.
Can we look at general physical findings, not abdominal findings? General physical findings.
Pallor is proportional to the bleeding in placenta previa because we can see the bleeding, but it is disproportionate in case of abruption because sometimes it can be concealed.
Correct. Any other findings? Tachycardia is also a finding which is noted. It can be seen in both, but it is more pronounced when there is excessive hemorrhage or when there is abruption placenta. Right. So we have looked at few general physical findings and we have looked at some abdominal findings which can all help distinguish between. Right. So now, how do you diagnose? What are good diagnostic modalities?
Sir, ultrasound is a gold standard, but also you can use transvaginal scan, which will precisely tell the location.
So let's agree that placenta previa is well diagnosed by an ultrasound. Abruption placenta.
Abruption placenta is mainly medical diagnosis based on sudden plain vaginal bleeding, uterine rigidity, and non-restoring fetal heart rate. Ultrasound,
can we stick to ultrasonography?
Yes. Ultrasound maybe reliable, but it is not always reliable. It may show a retroplacental clot in some cases, but a normal ultrasound does not rule it out.
So that is the take-home message. The normal ultrasonography does not rule out an abruption placenta because if there is a small clot, an evolving clot, it does not reliably get picked up using an ultrasonography. So ultrasonography is not the best modality for an abruption placenta diagnosis. Okay, so I'm going to give you all a scenario. Let's see if you can answer this, right? In an emergency presentation, there is a primary rata, 36 weeks, BP 150-100, severe abdominal pain, some altered bloody vaginal discharge, fetal heart rate is present, 120 beats per minute, PV 4 cm dilated and 1 cm long cervix. Membranes are intact. What should be done?
Ultrasonography
ultrasonography
to confirm the conceived abruption placenta.
Considering the preceding discussion on the ability of ultrasonography, who else wants to see ultrasonography?
Ultrasonography will tell us about the presence of the retroplacental clot.
So I disagree because in this clinical scenario, the cervix is already dilated, the uterus is already active. While the ultrasonography may be able to pick it up, but you have a better clinical method which would be artificial rupture of membranes. Right? If you got artificial rupture of membranes, there is going to be an instant diagnosis if there is anything inside the uterus, it is going to come. Right? So ultrasonography, use it by seeing. That is the take-home message from this kind of case. Right? So moving on. We looked at abruption. We'll go back and we just look at how are you going to manage a case of placenta previa. That is, you have a placenta previa confirmed, complete placenta previa. It's a term gestation, and patients must come with bleeding. What would be the management?
Emergency assistance.
Yes. So emergency assistance, there is no ambiguity in this line of management. Please be aware that there is nothing. So what steps would you do to prepare for such a procedure?
Availability of anesthesia, neonatologist, operation theatre facility, then blood group, blood and blood products available at the consent.
Yes. So many things to be arranged. Suppose you are an operating surgeon and you are intraoperating. What are all the various specific steps that you will take to ensure a smooth procedure?
So to avoid cutting through the placenta, and after the uterine incision, look for the amniotic sac and rupture, proceed to delivery and then handle the placenta.
Correct. So till now everything went on smoothly. Now you delivered the fetus and over extra. Now the placenta is not coming. What are you thinking?
It would be the placenta accreta. This one.
Correct. So a placenta accreta scatter is very closely related to antepartum hemorrhage case. However, since it is a separate entity in itself, we are not going to cover it now. We will stick to our topic of antepartum hemorrhage and we will come back. Right. So complications of abruption placenta?
So PPH, DIC, acute kidney injury, and bones.
Can you please elaborate? In case of extensive placental circulation, the thromboplasins are released into the maternal circulation, triggering widespread coagulation activation. This leads to consumption of clotting factors and platelets, resulting in bleeding tendency. So, clinically, patient may present with oozing from the IV sites, prolonged clotting times, and multi-organ dysfunctions.
Okay, all these are right. So, how do you manage this? Suppose there is DIC, how do you manage?
So, management of DIC in these cases would involve addressing the underlying cause, prompt delivery, and supportive therapy with blood products, including fresh frozen plasma, cryoprecipitate, and platelets as needed.
So, we've kind of come to the end of this discussion. I encourage all of you, please go back and see Mrs. A, who is admitted in the post-operative ward. She underwent emergency C-section for placenta failure today. Then also check out Mrs. Y, who is in the postnatal ward. She delivered vaginally. She had an ruptured placenta, and her mother is in the ward, but baby is in the ICU. Also, not all of you, at least maybe one or two of you, please go to the ICU and check out Mrs. Z, who had a ruptured placenta almost 5 days back. Still, she's struggling with the ICU, waiting to be reached. Right? So, please do the clinical connect for these patients. Right? So, thank you for your active participation. We have come to the discussion on APH. I want you to go back and read further reading Mugalia and clinical obstetrics, Data obstetrics, and Williams obstetrics for further reading. Later, we will assess you based on some multiple choice questions.
Thank you. May we please invite Professor Vinita Singh Madam for the feedback? Unmute yourself, ma'am, please.
Very good evening. I think it's almost good afternoon coming to be good evening. So at the very outset, I would like to congratulate Dr. Parag Biniwale, who is a dynamic chairperson of ICOG FOGSI, who has initiated such a wonderful program, and also to Vice Chair Ashok Kumar. I would like to congratulate you, sir, because this program is really a very good program, and also to Dr. Sarita, Secretary, who is working so hard, and Dr. Vidya Tobi, my dear friend, you are coordinating in such a nicer way of this program. This is going to be very beneficial for all the students and all teachers also, I think. And how can we forget to acknowledge Dr. Vandana Agrawal, who has done so lots of work and hard work behind this, organizing this program. So, Vandana, you have done a great job. And Dr. Madhav, who has done a wonderful job and has sent his video talking on APH control discussion. So this control discussion is, I think, one of my favorite. Always I feel that control discussion is very good, especially for the postgraduate students. So Vandana, can you share this my PPT?
Yes, madam. Gauri, please share ma'am's slide.
So control discussion is very good in way that the control is absolutely in the hand of teacher, and we can know that where the students are lacking behind. So this is a wonderful way of teaching in nowadays, where NMC, National Medical Council, is working so hard to coming up with so advancement in methodologies, and they are coming in so much of a nicer way of teaching UG and PGs. So we all know that medical education is a combination of art and science, and it has become more scientific and rigorous. What we had, previously we used to have, one teacher used to come in a class, he used to give lecture, and that's all. And हमने कुछ सीखा या नहीं सीखा, but that was fine. So now this is changing scenario, and I think it's very good for teachers and for students also. And what we do in this, that the problem based and other forms of active self-directed learning has been in the mainstream, and teachers is also we can find the problems, and also we give the solution. Suppose we are talking to any students, if there is any problem, immediately we can find the problem, we can solve we can give the solution also. So next. So in this control discussion, as I already said, that there is a small teaching group in which the teacher guides and discuss the ensure specific learning objective which are fulfilled rather than free discussion among the students, means that everything is in the hand of teacher, and students are not, they are free to discuss. They discuss with teachers only, and we teachers, we come to know that yes, where is the problem with the students. So this falls under teacher controlled activity, what we are saying, and the general direction of discussion is strictly controlled by the teacher, which I am already saying, and this is the very good part of this controlled discussion. Next. So in this, there is a small group, and we start with the closed questions and come with the open questions. And initially, what we do that we go with the factual knowledge what the students have, then we go and comprehend the knowledge, then analyze the knowledge, and then we come with the synthesis. So this is very good, and the discussion method of teaching is, these are the various promotes critical thinking, interactive and participatory, that is more with the teacher, builds communication skill. So this, in this type of discussion, usually I think it is
Hello, Dr. Vinita, are you there? We are unable to listen to you.
Yes.
I think her connection is lost. So shall we? She joined. I think.
Yeah, so now, so it also helps in covering essential learning objective while keeping all the participants engaged. Just a minute.
You have joined from the two devices. So
Okay,
one
yes,
you have
yes,
to
yes. I
close.
was trying to join. So, helps in.
Anyway, you please conclude with Dr. Vinita. That's okay.
It's all right, ma'am. You can just say, we'll show the slides.
No, her connection has got some problem.
So in this control group discussion, of teaching, in which the teachers has got the control on the entire students. We know where the student is lacking, and we know what is the problem, and immediately we can solve the problem also. So I'm in very much favor of this control discussion. So thank you very much.
Thank you, ma'am.
Thank you, Dr. Vinita, for joining, and all the best. Thank you.
Thank you so much, madam.
Yeah. So let us move to the session 4.
Yes, ma'am.
Please display the series. And it is my pleasure to introduce Dr. Kavita Bhatti, who is a professor, head of the department and faculty of the Department of Medical Education. And we will be discussing the last one, that is think and pair. So over to Dr. Kavita Bhatti. And our expert is Professor Tamkin Khan. We know her from stillbirth societies of India. She's a founder, she's a president, she does a lot of work, more than 30 years of teaching experience. So she will be giving her expert comment at the end. So over to Dr. Kavita. Please share your presentation as well as video.
Yeah, thank you so much, Dr. Vidya ma'am, for the kind introduction. And I'm really honored to have Dr. Tamkin Khan as the expert in my session, good friend of mine.
Yes.
And
Yes.
at the outset, I would like to thank the ICOG office bearers for giving me this opportunity of being a part of this great initiative from ICOG. So I would like to share my screen. Can you see it?
Yes, ma'am.
Okay.
Yes, ma'am.
And also I thank Dr. Vidya Tobi ma'am and Dr. Vandana for coordinating with us so well. Dr. Parag sir, Dr. Ashok Kumar sir, and Dr. Sarita also for including us in this very important online teaching program. So the topic given to me was think, pair, and share. It is a very simple, effective strategy for teaching, and also we should consider it as one form of formative assessment. So I will take you through the introduction, steps of think, pair, share, the prerequisites of this strategy of teaching, the advantages and limitations of this teaching tool. So by the end of this session, you'll be able to explain what is think, pair, share strategy, comment on the prerequisites of think, pair, share, list the advantages, and also discuss some of the limitations of this teaching tool. So think, pair, share is a structured collaborative learning strategy which includes 3 steps. The 3 steps which involve think on given topic and formulate individual ideas. Share this with these ideas with the peer or your partner, and then share it within a small group or large group. So the first step is when the teacher poses a question on a particular topic and the students get time to think independently upon the question. So the students has various ideas, solutions, and probable answers on which they think, and they can also jot down some on the writing material which may be provided. The next step is to pair up. So the students pair up for discussing their thoughts with the immediate person who's sitting close to them, and they can then articulate their ideas together and again jot down on the writing material which is provided. It gives opportunity for considering other students' ideas. And it also helps in bringing out ideas for the students who are actually shy of presenting. Now, the third step is sharing. So the pairs share their ideas within a larger group or a class, and one finds that students are more comfortable presenting to a group when they have a partner who can support their thoughts. So the prerequisites for think, pair, share is when you decide a session for a topic, a particular topic has to be decided well in advance, define the objectives of the session or the topic, and then give a detailed description of the strategy to the students. So you have to also provide the timelines, how much time needs to be involved for each of the 3 steps, and also provide guidelines for participation in the strategy. So you have to really elaborate on this method of teaching. Specify time limit to avoid chaos, and also discuss evaluation criteria. With each teaching tool, there are weaknesses and strengths. So what are the advantages of using this think, pair, share strategy? It actually engages all students from the classroom. The quieter students get opportunity and also brings down the level of anxiety. Any misconception of the student can be rectified immediately. It encourages and supports higher levels of thinking, fosters active learning, and it promotes deeper understanding of the topic. It also allows to develop different perspectives of the same task, and also addresses diverse learning needs, because each student will require and will have different needs while learning a particular topic. It encourages collaboration and also develops communication skills. What are the limitations? Because when you ask the students to share with the partner, then it can be a little noisy because of loud discussions, may not allow for individual assessment as easily as direct questioning, and some students may struggle to engage in partner discussions. Because of the time limits, it can also put time pressure on the students. There are various variations of this strategy. You can also think of doing think, pair, square, and share strategy, which again I will be showing in a video from Department of OB-GYN, CMC Ludhiana. So this think, pair, share strategy can also be used as a formative assessment, and it brings out the insights into students' understanding. So while they're discussing, the teacher can see what discussions are being carried out during the pairing session, and also when the students are sharing it within the small group or within the class, then also the assessment can be carried out. It provides immediate support and feedback. So we'll go on to the video. And Dr. Vandana, can you please help in sharing the video?
Yeah, yes, madam. Gauri, could you please allow madam to share?
Yes.
Good morning, class. Good morning. We are going to discuss an obstetric case today. I hope the audio is visible. If you
Yes,
remember,
ma'am.
can be heard? Audio?
Yeah,
Yes,
yeah,
ma'am.
it is heard.
Yes.
Yeah.
It is heard.
Thank you. During pregnancy. So it was a lecture, and after that we had some discussions. But today's class will be based on think, pair, so share. This is the briefing session where we are actually telling them about think, pair, share, because this is a new activity which is being enforced within the class. Some time for think. That is, you have to think. So a topic which was already covered during one of the lectures previously is now being discussed in a small group. Sitting on the left side of your seat. So like Sakshi can pair up with Sharan Preet, Jagmeet can pair up with Sonia, and the rest of you also can pair up with the person. So we are putting some rules and time limits with the partner. So the student may be allowed to think and individually for 2 minutes, then pair up with the partner for another 2 minutes and share it with the partner. I will give you 1 minute for thinking, and then for 3 minutes they can share it with the small group or the class. Whole class. So is it clear to you? Yes. Yes. So shall we start? Yes. So now we will discuss a case. A woman has come in emergency room and she's been brought to her. This was actually a case which had come to emergency with features of shock. The diagnosis of ruptured ectopic pregnancy. So the case scenario was put forward to the students. Positive 2 days back, and she had an episode of syncope at home, and she had acute onset of pain abdomen, also associated with bleeding per vagina. So when she comes to the casualty or emergency room, you find that her pulse rate is high, 120 beats per minute. She has hypotension 90/60, and her respiratory rate is 20 per minute. On abdominal examination, you find that the abdomen is distended and it is tender. Locally, she has some amount of bleeding. So now you have to tell me the diagnosis, points in favor of your diagnosis, and the initial management that you do in the emergency. So a specific question has been put forward to the students to think about this case scenario. How to diagnose and do the initial management of a ruptured ectopic pregnancy. So they allowed some time to think on their own. So now your 1 minute is over, and you have to share your points. Been given 1 minute to think about the case. You will get 2 minutes, and you can discuss the case with the partner on the left side. And then they pair up with the person who's sitting with them on the left side, and they share their thoughts among the two. I hope you got enough, you've done enough discussion, and you have come down to certain conclusions regarding this case. Now 2 minutes are over. So I would ask each pair to come in forward, and one person from the pair can come and share
Casualty with 8
their
weeks
answers to the
Women's
class.
pregnancy test is positive.
So this is the share.
And she has acute abdomen and there is bleeding per vaginum. She has come with the vitals of pulse of 120, BP of 90/60, and episode of 1 syncope. So our
So
probable
here you can see that they get the support of the partner,
points in favor
and they have
she has 8
actually sharing their thoughts together. So it helps in bringing out the shyness from the
signs of
student.
her pulse is high on
But
a
sometimes there are flaws also. One of the students may be very talkative and more dominant than the
on
other,
her abdomen examination, guarding rigidity is present.
not giving a chance to the second person to speak.
Then
So
I'll
these are
first
some
ask
of the
diagnostic
limitations of
suspects of
this
pregnancy, and our
teaching tool.
management will be first we will secure the airway,
then first we have to stabilize, basically we have to stabilize the patient vitally. We have to secure the ABCs, that is the airway, then
So the time limit which was given to them to share was 3 minutes. So within 3 minutes, they could put forward the answers to the diagnosis and management of ruptured ectopic pregnancy in the emergency room.
blood and IV fluids build up the BP and stabilize the patient. And then we have to explain the high risk situation to the relatives and the patient and take consent for laparotomy. And we will shift the patient to OT after initial stabilization.
So I think that was very well thought. Here the facilitator or the teacher can give her comments
Second pairs who can
and
come
feedback.
forward and share the points for the differential diagnosis of this case and
So
the
now we call upon the second pair
management
and they can
casualty.
also share their answer with the rest of the class.
And put your thoughts.
The possible diagnosis of the patient which is presented to casualty uh, is ruptured ectopic, and the points favoring to the diagnosis are amenorrhea of 8 weeks with UPD positive, uh, pain abdomen, and bleeding per vaginal. And the differential is abortion, but in that case in this case there will be hemodynamic instability, but in abortion case there will not be the signs of rigidity guarding. So and when the patient
So
comes,
this patient did not have rigidity guarding, but there was abdominal distension and tenderness. So that goes in favor of ectopic.
Since they deviated from the answer, the
in casualty
correction was done by the facilitator.
to confirm the site of the ruptured ectopic and hemoperitoneum. And for the management, as the patient has come to you in casualty, in shock, so initially, first of all, we have to secure IV lines by putting two large bore IV cannulas to resuscitate the patient according to ATLS guidelines. Then after that, we have to maintain airway, breathing and circulation of the patient. We can also catheterize the patient so that we can check the strict input and output charting. And after that, we have to explain all the high risk factors related to the patient, to the relatives. We can explain the risk of mortality, morbidity, and we have to also explain the risk of bleeding, excessive bleeding, and they might require blood transfusion. And after that, we have to send investigations, which include CPC, cross match, and viral markers. And after managing, stabilizing the patient, we have to proceed for definitive management.
So that was well covered, and I think you have managed your patient well. The initial management, you have covered everything. And I would ask somebody else from the class, any other pair who wants to put in more points, if anything has been.
So anything which was missed by them can be taken up by the rest of the members of the
I would
small
like to
group.
add that while taking the consent, we should ask other points like as you told about morbidity and mortality, but we can also tell them about the need for blood transfusion, increased stay in hospital, increased cost of treatment, and that's it.
Okay, I think those were very good points which you have added. So now we know how to diagnose
So
ectopic
here you can give immediate feedback as well.
as well as the initial management in the emergency room.
Now this is a think, pair, square, share activity, which is a variation of think, pair, share.
Square and share.
So again, here we need to explain
You have to think in
regarding the learning teaching method
the person who's sitting
and give them proper instructions how it needs to be followed up.
with that person. that will be for 2 minutes. Then you square up. So like two of you can. So you have to pre-decide the partners and how they are going to square up. With you all. And also tell the time limits for the discussions. For 3 minutes. And then again, the four of you, one person can share the thoughts with the larger class. So that again will be for 3 minutes. So 1 minute for thinking, that is think, pair for 2 minutes, square for 3 minutes, and share with the class for 3 minutes. So is it clear to you? Yes, ma'am. So once the instructions are given clearly, then we go on with the activity. And here again, we are going to put forward a case on obstetrics. And she's concerned about the pregnancy. So I want you to tell how you will counsel that lady. So here I've given a case where a lady who comes in a first trimester with the thalassemia trait, how we need to counsel her regarding the pregnancy. So I've given them time to think. So now 1 minute is over and we will now pair up with the person who's sitting on the left side. So Sakshi, you can pair up with Sharanpreet again. Jagmeet, you pair up with Sonia. Our group will share with Shamli and Egla with Garima. So now they share. You will get 2 minutes. With the partners. So here I've told them to pair up with the person who's sitting on the left side. So a time limit again has been given for 2 minutes. Is over, and now you will get time pressure is also important. Otherwise, they will deviate and start talking besides the topic. Egla and Garima. So now we are putting them in squares. On the table. That is four together. Same with you. We have formed groups of four, and you will get 3 minutes to share your thoughts on this question. So they might have different perspectives, different ideas on this topic and case. So they get a larger number of students to share and then write down their answers. And while they are sharing the ideas among themselves, the teacher can actually move around in the classroom and see what contribution each student is doing towards answering the question. So it is like taking a formative assessment also. And now from the four of the students, one person is the leader who comes forward to share it with the rest of the group. So again, here a time limit should be given.
Disease per se, because she's just thalassemia trait and not major. So that is why she has not had any symptoms up till now. Since she's a thalassemia trait, only one copy of the gene is abnormal. So till now she has not experienced any symptoms. But now since she's pregnant.
So after this video making, when I asked my students how they felt about this method of teaching, they were happy because they said that it builds up the confidence and also helps in better communication and the skills which are required to present.
Done for thalassemia screening and its importance. So first we'll explain her that if the husband comes out to be normal, that is no trait is there, then there is no risk to the fetus, to the baby. But if the husband also comes out to be trait, then there is a 25% chance that the baby will be a thalassemia major case. That is, it will be a full-blown disease, and 50% chances that the baby will also be a trait, that is thalassemia minor, and 25% chance that the baby
When we follow this in our regular class activities, we have to see that one person does not become leader all the time. So for different topics and different discussions, always the leader should be changed, because then the quieter students do not get a chance, and some of the students are more actively involved while the rest become
passive.
And if
As a
the
facilitator, one has to see to that.
category that is thalassemia trait, then the baby can also have a normal life and will not require any much transfusions. So accordingly, we can counsel the patient. So next, if the husband comes out to be thalassemia trait, now we want to see if the baby is major, minor, what is that? For that, we have to counsel her for amniocentesis or chorionic villus sampling for diagnosing which category does the baby fall in, and then accordingly they can make an informed decision. And then after explaining the importance of partner screening, the prenatal testing, and all these things, we have to explain the patient that during pregnancy there is not much risk to the patient per se, that is the mother per se. Only her baseline HB will be on the lower side for pregnancy, so that she has to take her iron supplementation and folic acid and take an iron-rich diet through her pregnancy to keep the HB levels within the normal range. And then for the baby, there is risk of, as we have discussed, that there is a risk of thalassemia major, thalassemia minor, and the risk associated with that. And then we also have to counsel the patient for the usual antenatal counseling, like the family planning counseling post-pregnancy, and post-delivery. We have to counsel her that she can breastfeed the baby. There is no contraindication for breastfeeding, and if newborn needs to be screened for thalassemia as well.
So I think Sakshi, that was very well covered. I think you put all the points regarding the answer of this question. And if there is any additional points which the other groups want to discuss, yes, our group.
I want to add that we should also inform the patient about at what weeks they have to get the chorionic villus sampling and amniocentesis done, because they will not be knowing exactly at what weeks they should get it done. So because it's very important, we can give them option regarding termination or continuation of the pregnancy based on the results.
Yes, that was a very good point that you have brought out. We have discussed both the questions according to think pair strategy. I want to debrief and I want to get your thoughts on how you felt. So this is the actual debriefing that I did with all the students who were involved in video making as to how they felt, because this was the first time that I implemented this type of teaching tool in a PG class. We have done simulation based teaching, but think pair share, I think I did it for the first time. So I wanted to debrief on how they felt about it, what was good about this strategy, and what could have been done better. So this was a debriefing session, which is very important. So you can share your thoughts. And not only about the activity, but also the discussions which were involved in the management of this patient who had thalassemia trait. So what ideas were put forward and what were missed. So all that can be taken up in the debriefing session.
And then it also brought confidence to speak in a larger group and to keep our points, to support our diagnosis in our management. So it was a very good activity.
So I think the discussion within the group adds on to your confidence, gives you time to think and share your thoughts. And so they're actually sharing their thoughts about how this think pair strategy helped them. About this interactive session. Shamli?
Ma'am, I felt it was very spontaneous and quite like real life scenarios. Like it was timed and well balanced. And also, like if an individual is very hesitant to speak, so in a group, everyone feels comfortable and they can voice their words.
Yeah, that is one very good point that you have brought. That so this think pair share is a very simple but very effective and also easy to be implemented in our classrooms. Does not require much preparation in advance.
Ma'am, it was a very interactive session. It is a kind of stress-free session because in this we will have time to think, to share with our partner, and it will give you more confidence.
So it may be difficult to do it in a UG class, especially when we have 100 or more than 100 students. But for postgraduate teaching, I think this is a good strategy and should be introduced. So with that, we end today's class. Thank you, students.
Thank you.
Thank you so much.
Thank you, madam. Professor Tamkeen Khan, madam, you could please give your feedback.
For your expert comments.
Now you have to unmute yourself, ma'am. Unmute yourself, ma'am.
Yes. Sorry, good evening, everybody. I think this video was excellent. It was so well made. And not only it demonstrated the technique very clearly, it also demonstrated the qualities of a good facilitator, the body language, the way the feedback should be given and taken, the way you guide the students, the questioning technique, everything was demonstrated very well, and it should be archived in the resources. And now coming to the main topic, think, pair, and share. We all have seen this, this cartoon. I have taught Snoopy to whistle. I can't hear him whistle. I said that I taught him, not that he learned. So when we are teaching somebody, it is not always that the person is learning. We don't want to see these faces in our class. Maybe this will do, but I don't want to see this kind of faces also in my class. Though they are concentrating, I want to see a happy class. I want them to be sharing and pairing and learning together. And think, pair, and share is one of the easiest techniques to be used both for undergraduates and postgraduates. It's a structured collaborative learning strategy. You already demonstrated very well. And it starts with independent thinking. That is the first step. And then the students, they process that information and also practice communication and problem solving. What are the advantages? Dr. Kavita has already demonstrated, but something very important that Dr. Ashok said initially, that the teaching should shift from that teacher-centered learning to student-centered learning. And that is exactly what happens in Think, Pair, and Share. It creates a student-centered learning environment, and here the needs of individual students are taken care of, and they take different pathways within the same classroom. Also, another benefit is that students process the information, and if they're doing it at a slower pace, the others are there to help them. They get a chance to rehearse before they share their ideas with the class. So the shy ones come out very well. It develops communication skills, and also it helps student engagement because they are doing the learning all the time. They're doing it themselves. Then it also promotes, it also helps them develop their presentation skills. And they become, from simple unreflective thinkers, they graduate to critical thinking and learn those skills. Apart from that, they collaborate in the listening process, and the methodology I will not repeat. It has already been demonstrated and already been discussed. There was a question raised by Dr. Kavita whether it is good for undergraduates as well. So I have been using for large classes, large group teaching as well, a slight, deviation from the classical technique. And that is, I say turn, pair, and share. So maybe if I have given them or taught them or discussed with them the causes of obstructed labor, I'll say just turn to your left, and the student sitting next just enumerate the causes of obstructed labor. So just breaks the monotony of the class, and it gives them some interaction between themselves, and it becomes more interesting, the whole class. It's a handy tool, and I have been using it for a long time. Then the students also return back to the class mentally. Another variation is think, write, pair, and share. Dr. Kavita was discussing whether it can be used as a assessment method. So when you're asking them to write, first think, then write down maybe the causes of placenta previa. So then they submit those papers and then it becomes their formative assessment. But usually we do not use them for high stakes examinations, but both for formative and summative assessment it can be used. So already another variation was demonstrated by Dr. Kavita: think, pair, share, and square. And then of course there can be a homework edition. You ask them to do the thinking at home, they come and discuss, pair, share, and then with everybody in the class. Then also you can use some digital platforms. Maybe you upload a video, and then they can come back and then discuss that video in groups. Then again, what are the challenges? Some challenges like, my students are not talking to each other. How do I get them to engage in the activity? You can very well add an incentive. Chocolates and even eclairs, they work very well for this. Or you may use icebreakers. And then please remember, it is assessment which drives their learning. Whatever you do in class is immaterial because their focus is PG NEET. So use must-know areas and tell them that this is a must-know area to bring them back into the class. Endless discussion going on. How do I transition from and come back to the topic? Well, this proves that your students are engaged in the discussion. No need to worry, just celebrate. And then ask them to refocus the class, set time limits, and define the scope of the question. Signal the end of the discussion with a quick phrase like one last point or one more point before, one more input before we move on to the next phase. So one student dominates, another doesn't participate. What you can do is that you prevent one student from dominating, set time limits, and monitor student interactions closely. To increase individual accountability, ask students to write down their ideas and then turn to their partner and submit those points that they have written down, and pair shy ones with supportive ones. That is what hand-holding and collaboration is all about. Students ask, can they use their cell phones or laptops? Yes, of course you can allow that. Think, pair, share is a very flexible method, can be as simple as you want or can be as complex as you make it. Use of online resources or research tools, definitely I would allow that. Ensure, please, that technology only enhances their learning rather than detracts from the discussion. Sometimes, the problem is that for small groups, you need many classrooms, or you have only large classrooms. So Dr. Kavita already demonstrated the use of a large classroom for a small group discussion. So space, infrastructure, seating arrangement, if you are interested, you are passionate, you can do it and you can accept that challenge. Managing time and transitions effectively, use timers like Dr. Bhatti was using, signal transitions with verbal cues. Let's hear one final point, incorporate a quick reflection activity that was demonstrated in the video to reinforce that learning for deeper learning. So it is a very useful tool for both formative and summative assessments. Ask them to submit their responses, or you could also ask them to submit their reflections and grade those reflections for assessment. So last slide, great learning happens not in isolation, but in connection. When minds meet, ideas bloom. So gone are the days of, teacher-centered learning. We have to shift towards student-centered learning, collaborative learning, and that is what pair, share, and think, pair, and share is all about. So thank you very much.
Thank you very much, madam. So Dr. Kavita Bhatti and Dr. Tamkin Khan, madam, has really touched upon all the finer points of this method of small group discussion. And really, ma'am, I appreciate and I'm thankful to you, Dr. Tamkin Khan, madam. You really simplified the process. In simple words, you explained the process of uh, think, pair, and share method. And I think everyone has understood and how to go about it has been demonstrated in the video by Dr. Kavita, madam. So it is really a very, and before that, I would also like to tell the audience that, see, Dr. Kavita Bhatti, madam, is from a center where medical education is a part of their activity.
Yeah.
And Dr. Tamkin Khan, madam, has done the FEMR, which is another important degree or a milestone in medical education. So we have all these great experts with us today to initiate this process of teaching learning method by the ICOG. And all these experts with all their experience and background in medical education. And again, JIPMER, if you see, JIPMER again is a institute where medical education is in full swing, and they sincerely and they are making emphasis on that. Then Dr. Niharika from Maulana Azad Medical College, she is a part of the medical education team of Maulana Azad Medical College. So all are expert, and that is why we have tried to include all of them to convey the message that yes, medical education is evolving, and medical education is a continuum which provides a great experience of learning. It is, as you are always telling, or all of you are telling, it is a communication, it is a sharing, it is the learning which is by way of easy understanding. It is not a simple didactic 1 hour lecture and you go away with the different mindset. So these, you should enjoy learning. So these are the methods which will help us to understand these evolving methods and try to make the learning very simple. So thank you all. On behalf of FOGSI ICOG, I would like to express my sincere thanks to all the experts, all the faculty who have participated, and all the faculty and seniors who have taken pains to stay with us throughout the program, and they're still with us at this moment. So thank you all, and I hope with your feedback and suggestions, we'll be able to improve further. This is a small our effort in this direction of simplifying and spreading the process of medical education. So now I hand over to Dr. Vidya Thobi and Vandana to formally say a vote of thanks and close the program.
Thank you, Dr. Ashok Kumar, and all the stalwarts, all the teachers, and all the participants. Really, it is a great pleasure for us also to initiate such type of programs. And sometimes we can share also. Here also we are doing the same. We are think, pair, and share. We are doing the same things amongst the teachers, and I appreciate the efforts of ICOG and FOGSI for taking over. Vandana, please, can you give the vote of thanks
Yes,
for all?
madam. Yes,
Yeah.
madam. All right. So I'll take 2 minutes. So with this, we come to an end of our first webinar on Odyssey of Teachers, a series of online learning methods. This academic endeavor has been possible due to the blessings and hard work of numerous individuals. First and foremost, I would like to thank Professor Ashok Kumar sir, the Vice Chairperson of ICOG and my head of the department, for conceiving this program, along with Dr. Parag Biniwale sir, Chairperson ICOG. We are extremely thankful to Dr. Sunita Tendulwadkar, President FOGSI ICOG, for encouraging and supporting this venture wholeheartedly. We are grateful to Dr. Suvarna Khadilkar, Secretary General FOGSI, Dr. Sarita Bhalerao, Secretary ICOG, and Dr. Sheila Mane ma'am, Chairperson-elect ICOG, for blessing this program with their esteemed presence. We are very grateful to Professor Vidya Thobi madam, Vice President-elect FOGSI, who has helped in coordinating this webinar, guiding and motivating us throughout every step. Without madam, I don't think this webinar would have been possible at all. We are extremely grateful to all our eminent faculty members across India who have been working tirelessly since past few months for this webinar. Professor Neelam Roy, Professor Niharika Dhiman, Professor Vaishali Kode Nayak ma'am, Professor Lata Chaturvedula, Professor Kavita N. Singh, Dr. Madhava Prasad, Professor Vinita Singh, Professor Kavita M. Bhatti, and Professor Tamkeen Khan. We are thankful to all the demonstrators who participated in the videos. I hope it was a fun-filled learning experience for all of you. We are extremely thankful to the backend team of FOGSI ICOG, Mrs. Neelima, Mr. Jignesh, Ms. Gauri, Mrs. Shreya, Mrs. Neha, and everyone else for bringing together this webinar. Thank you. Last but not the least, we would like to extend our deepest gratitude to all the faculty members and dear students who have joined us today. And we hope this webinar and the concept behind it has ignited a spark in you for continuing improving as a lifelong learner. So until we meet next time, hopefully in a month or so, wherein we will bring in a different teaching and learning methodology without any technical background glitches, hopefully. Until next time, happy learning and take care. Thank you.
Thank you. I hope all the videos will be uploaded at the ICOG website. And we are really sorry, Lata, because we could not play it properly, but that will be at the ICOG website, and there you can watch. Means all the delegates who want to again watch various methods they can definitely watch there. Thank you very much once again. And let us hope next month with another teaching learning method and another discussion will come back. Thank you very much.
Thank you so
Please
much.
stop recording.